Are those slides showing up for you guys? Oops.
Yes.
Okay. Oh, there it goes. Sorry, it took a second. And I think this one's, okay. Does that show the slides without my notes page? Is that looking right?
Yes, yes.
Okay, good. Okay, so what I want to talk about today is going to be our preventative screenings in HIV. So this is from a primary care standpoint. And they've recently come out with a new guideline set. We used to use the guideline set from 2013. And now in 2020, we have a revised version we were waiting for quite some time. So I'd like to go over those today. These are just my disclosures. I am on Speakers Bureau for ViiV as well as Gilead, but it should not impact the talk today. And then we do receive Ryan White funding for our clinic. Currently, I am not a part of any experimental or off-label drug therapy. Our objectives for today. So I'd like to go over just some of the common barriers to care. I know we talk about these a lot, but just some of these that were talked about in this guideline set. We're going to go through just routine preventative screenings. This is going to cover cervical cancer, anal cancer, breast cancers, and colon cancers. Some of these recommendations are the same for non-HIV versus HIV, and some are different. So I'm going to go over the differences there. Preventative screenings for STIs. So it'll include syphilis, gonorrhea, chlamydia. Preventative screening for osteoporosis. Routine screening for syphilis, tuberculosis, and hepatitis. Routine screening for lipids and diabetes. And then just preconception counseling and contraception in our female patients. So these are the two guideline sets. Initially was placed in 2013 by IDSA, but they did do an update to these guidelines with some changes in 2020. So that's what I would like to go over today, but it's really a good reference. It's actually a pretty good read. It's divided nicely by the different categories and the recommendations for each. So just barriers to care and to compliance for our HIV patients. Screening questions that we will use in our clinic, and these are used through most Ryan White funded clinics, as they've found that these are some of the most common barriers to patients staying in care or staying undetectable. Our mental health, substance abuse, and nutrition. Are they suffering from things like depression that are keeping them out of care or keeping them from remembering to take their meds? Are they utilizing substances that are affecting their compliance? And then do they have access to food? Some of our regimens still require food for absorption, and maybe they don't have a means to get food. Other barriers can be things such as transport, housing, culture barriers. Some of the things that we do through our clinic is that we do screen for these when they see their case manager. At all of our appointments, provider appointments, we screen for the mental health with using a PHQ-9 screening tool. And then we screen for substance abuse and nutrition by asking those questions. We will, if somebody speaks another language, we do have quite a few Burmese speaking patients and then also Spanish speaking patients. We use a language line on an iPad that we can use. We also have several staff members that speak Spanish that can translate. And then, of course, if patients sometimes will bring their own family members, but most of the time they come alone and we're using the language line. They're usually screened by their case manager for housing or transport issues. We do telemedicine in Poto and McAllister just to try to prevent patients from having to make that drive. And if they come from out of the Tulsa area, sometimes we can even provide things like gas cards. So moving on to some of the cervical cancer, or some of the cancer screenings, we're going to do the cervical cancer screening first. The recommendations are still to screen annually. The annual screening is checking for cytology, but also screening with an HPV screen after the age of 30. If there are 3 consecutive negative pap smears, it is okay to change the screening to every 3 years. And if they are negative for HPV and you've screened the HPV, it could potentially be even placed out to 5 years according to this guideline set. We want to include the cytology, HPV if they're greater than 30, and then also screen for gonorrhea, chlamydia, and trichomonas. And if we're receiving any abnormal cytology, or if you get back a high risk HPV, then these usually will be referred to OBGYN for colposcopy. It did state that if we do have ascus, or if you had a normal cytology with a high risk HPV, you could alternately repeat it in a year or still refer to OBGYN for the colposcopy. So those were the 2 choices that were stated in the guideline set. Most of ours, we go ahead and refer to GYN for COPO. It also had a section for patients who have had hysterectomy, which a lot of times this has been an area where we weren't given enough guidance by our HIV guidelines of what to do in terms of screening. On this guideline set, it says if the patient has had a hysterectomy for benign disease, meaning they didn't have a high-grade CIN or they did not have invasive cervical cancer, then a vaginal screen was not recommended in those patients. If they did get a hysterectomy for a high-grade CIN or had invasive cervical cancer, then they still need to continue with the vaginal screen. So anal paps is something that we do through our clinic, and this is basically anal screening, very similar to a cervical pap smear in that we are checking for the same things: cytology, gonorrhea, chlamydia, and HPV. And we're doing that by utilizing swabs that we insert into the rectum and send those for testing. There's no national screening guidelines for this test currently, but it is mentioned in this primary care guideline set, which is interesting. Previously, it was mentioned in the older 2013 guideline as a weak recommendation. And they had recommendations on that guideline set as either weak or strong. On this guideline set, they recommended that anal screening was recommended for any MSM that's having anal receptive intercourse, women with an abnormal cervical pap smear, or anyone with the presence of genital wart should be screened for anal HPV. If you have the means to refer them, so if you have availability to refer a patient to get the high resolution endoscopy, and had a means for basically if it turns up abnormal, what you're going to do, what we normally do, our general surgeons do the high resolution endoscopy, so we refer to them for a 4-quadrant biopsy. If you have means to do that, then they did state that anal screening would be recommended in that patient subset. They did not define how often we should be doing these screens. And in our clinic, we do them annually. In many Ryan White clinics, they're done annually. Remember, the risk of anal cancer in an HIV patient is exponentially higher than non-HIV patients. And so many Ryan White clinics have been doing these anal screenings for quite some time. Currently, there is an ongoing anchor study ANCHOR, anchor study. And this is what they're looking at is with anal screenings, when we get the cytology back is very similar to cervical PAPs. And so we will see the pathology come back as an ASCUS, an LGSIL, or an HGSIL. The anchor study is looking at those that come back as HGSIL, and if there's benefits of using either ablating or using topical agents such as Aldera or Condylox to slough those abnormal cells, and then repeating to see if we see improvements, so that we don't see risks of it turning into anal cancer, and that we see regression of the HGSIL. That's the ongoing anchor study currently. It's still ongoing, so we're still waiting results. We've done these anal screenings for quite some time through our clinic, and have really seen, like, I've seen quite a few patients that may have been an HGSIL that have regressed, and maybe now ASCUS or low grade, or maybe even reverted back to normal in some instances. Our surgeons, like I said, do the 4-quadrant biopsies, and then we'll give recommendations on if they need to utilize an agent like Aldera for some time, and then a repeat biopsy, etc. But hopefully we should have further guidance on that once we get results of the anchor trial. Sexually transmitted infection. So this guideline set recommended screening for syphilis, gonorrhea, and chlamydia at initial presentation, which we do in our clinic, and then every 3 to 6 months if at risk for infection. And so at risk for infection was defined as sexual activity, presence of other sexually transmitted infections in the patient or in the patient's partner, or could also be by local STI prevalence. And so I thought it was interesting that they had defined it as all those things. They didn't say how much in terms of the prevalence. But as we all know, here in Oklahoma through the pandemic, we have had a lot of syphilis, gonorrhea, and chlamydia currently. And so I think the biggest thing in terms of screening, we're talking about screening in terms of HIV positive patients, but even when we're screening and seeing these patients that are non-HIV, remember to check those patients with an HIV test, as the same risk factors that put them at risk for those other STIs put them at risk for HIV, and HIV can be transmitted a lot more easily during one of the other sexually transmitted infections being present than not. They did recommend that anyone that's having essentially vaginal intercourse should be screened for trichomonas annually. If you're doing an annual pap smear on your females, you're getting those. But even your male patients that are having vaginal sex should have trichomonas screening. Remember, if any of these STI screens are positive, we want to retest in 3 months due to high infection rates. Not necessarily that they didn't clear the infection to begin with, unless they're symptomatic, but if they're asymptomatic, even in 3 months to retest, because they do have an increased risk of reinfecting. We will oftentimes also educate patients when they're being treated for one of these to make sure that their partner seeks treatment, and then to abstain from intercourse for 7 to 10 days following treatment to make sure they're not just reinfecting each other. And then screening for gonorrhea and chlamydia can be obtained either a urine specimen, cervix specimen, anal specimens. We're also starting to screen now in our MSM patients for oral gonorrhea and chlamydia. So if they come in to get their anal screen, we're having the nurses do the oral screening at the same time. And that way, essentially, they can get 3-site testing. We do our urine screen for gonorrhea, chlamydia yearly already. Mammography, there's not any changes besides the usual guidelines, and those referring to the United States Preventive Services Task Force. And so those guidelines are the same as non-HIV patients, so no changes, nothing different there. Colonoscopy, same thing, as now I'm wanting to screen lower and lower, and I've got the letters grade A or B, whatever they recommended in the task force guidelines, but the screening colonoscopy recommendations for HIV versus non-HIV patients the same. DEXA is different. So baseline DEXA screening is recommended for osteoporosis in all postmenopausal women and in men over the age of 50. And this is because a lot of times the medications can contribute to premature osteoporosis. We can see a decrease in bone mineral density with any of our NRTIs, or our backbone of therapy. And we do tend to see that more with the older TDF, tenofovir disoproxil, versus our newer tenofovir elafenamide. So definitely people who have been on older regimens, it's something to think about. Sometimes if I'm trying to change a patient off of, maybe they're still on an atriplen, we're trying to modernize the regimen, or maybe make it safer. Maybe we're seeing a little bit of kidney dysfunction and we're trying to make a change. But sometimes patients can be hesitant. Sometimes I'll say, you know, there can be some side effects of those older regimens, and one of those can also be osteoporosis or osteopenia. And some of those patients will get a DEXA scan, and we will be able to see osteopenia or osteoporosis present prematurely. And that oftentimes will convince a patient to switch if they hadn't already wanted to switch. So sometimes I'll utilize it that way as well. Labs, they just went through a few lab screenings, and some of these had changed compared to the 2013 guideline set, if you had been familiar with that one previously. Lipid panels, you know, we do check those prior to initiation of ART. You want to check it 1 to 3 months after starting antiretrovirals, because remember that can change some things in your lipids. But also remember, and this one I've got to tell myself to remember too, when we change someone's therapy, change their ART, you may want to rescreen or relook at that as well, because you may be changing the dynamics of their lipids. If everything's normal, actually, you don't have to check but every 5 years. But if there's abnormalities, which with a lot of our HIV patients there are, and we see more of an aging population in HIV now too, then you may want to check those every 6 to 12 months if they're abnormal. Hemoglobin A1C. So previously we used to check these, and it was recommended to check it prior to initiating ART. And then to follow it thereafter. And most of the time we were doing an annual screening with an A1C. Last year, there was data that came out and also mentioned at the Ryan White conference that we were seeing that there are different HIV regimens that can actually alter our hemoglobin A1C. And so it's actually altering the results. And so we may be seeing some that are higher A1Cs when they may not actually have diabetes. So they are questioning the accuracy of an A1C when someone's on ART. So if you get your A1C at baseline, that's before they've started medications. By this guideline set, they actually changed it, and they recommend now following a serum glucose. And if you're able to get that fasting, checking that annually instead of an A1C, which may be altered by their antiretrovirals. So it was interesting, but they did change that recommendation in the newest guidelines here based on that data. For syphilis testing, an entry of care, and then annually, but if someone's at risk, you may be wanting to check that a little more often, so 3 to 6 months. If positive, I'll put here, refer to the health department. We've actually started treating a lot of syphilis within our own clinic. We're ordering and keeping the penicillin because as the health departments got very inundated with treatment of COVID, we found it was harder and harder to obtain records and be able to see if our patients had gotten their treatment. And so we've started treating it through our clinic as well. TB testing. So instead of using the tuberculin skin test, TST, we're using a quantiferon gold, which I know a lot of places are utilizing now instead of the old tuberculin skin test. That used to be hard to make sure to get the patient back in and read it within 72 hours. We want to do some type of TB screening, though. Either one of those is fine at the initiation of care. And then if their CD4 is less than 200, remember you want to repeat that once that CD4 it gets to be above 200. If it's positive, then a baseline chest x-ray is recommended. They may need to see the health department. We need to make sure it's latent tuberculosis and not active tuberculosis, because remember, a lot of the tuberculosis medications can interact with our ART. If it is latent tuberculosis, there's no interactions with the isoniazid. And we want to screen for tuberculosis annually. By the guidelines, it said to screen annually if risks are present, but we do it annually through our clinic. Hepatitis panel and entry of care. We saw that today with our case. We want to know what their hepatitis B status is as we're initiating ART. And we also want to know their vaccination status. And so we're actually checking their hepatitis B surface antibody to see if they have a titer high enough showing vaccination now at entry of care as well, so that we can get them vaccinated if they're not showing that immunity. And then we check hepatitis annually. If they're sexually active or have a history of IV drug use, the risk for hepatitis is still present, and so we're checking it annually. Viral loads were recommended. You want to check it every 4 to 6 weeks till they're undetectable, and then every 3 to 4 months. Once they get to undetectable and stay at undetectable for 2 years, it can be actually checked then every 6 months thereafter, according to these guidelines. And with the CD4, every 3 to 6 months. But if you're undetectable and your CD4 is over 300, you can check it yearly. And if the CD4, if they're undetectable and the CD4 is above 500, then it has been for 2 years, then it's optional for the CD4 count. So most of these, because of our requirements for our Ryan White grant, we're still routinely testing their CD4s and viral loads. But sometimes where access to labs or cost may be an issue, this may be helpful in terms of repetition of some of those labs. This is just the phyto information. Remember, some of these conditions, if you're testing for them, are reportable. That includes our STIs and our tuberculosis. And so I just wanted to put that up there. And it does also include HIV. And then I think the last slide is just to go over contraception and preconception care. Remember our women of childbearing age, and we just want to make sure that we're screening for this. We are screening our women at their appointments with preconception counseling. We want to do that at least once a year. Making sure that we ask them about their plans for having a child, if they're interested in having a child here or in the future, so we can plan their care and their antiretrovirals. Asking about contraception. I always think that this is a good time to ask them about their partner status. And I will oftentimes want to just know, what's the partner status? Is the partner HIV not positive or negative? Are they using condoms? It's a good time to bring up PrEP. It's a good time to, if the partner's negative, to talk about HIV testing routinely and those things. So it's just getting that conversation started. And then also, if they have different partners, making sure that they're disclosing status to their partners. And then importance of viral load suppression, particularly during pregnancy. We'll see our patients monthly during pregnancy, just to make sure that the viral load stays controlled, especially closer to delivery time. And remember, still no breastfeeding recommended in HIV pregnant women. Just a table showing some of the same things as we talked about with some of those labs and follow-up. So just in conclusion, we talked about cervical paps. Most of the time, those are going to be annually unless we have some consecutive negatives. Anal paps in a certain population subset, STI screening annually, routine screening for mammography and colonoscopy, but osteoporosis screening was different. So it's going to be postmenopausal women or men over the age of 50. Remember preconception counseling, contraception, and partner status. And remember the other barriers to care and screening for those barriers when we're seeing our patients, especially if it's patients that are having a little trouble with complying with meds and with appointments. I've put the resource there for that guideline set. It really is good if you're doing primary care and treating a lot of HIV patients, a great guideline set to follow. Remember, a lot of our HIV guidelines also come from our DHHS guidelines, and you guys may all be familiar with the AIDS Info website. I just wanted to see if anybody had any questions. Well, good. Well, hopefully, I hope that that was helpful for everybody today, just to kind of refresh through what things they've changed. I mean, there's not a ton that has changed, but the things that have, like the A1C and change to a glucose. I mean, these are some big changes in terms of caring for HIV patients. But I think it was just a good refresher just to remember as we all are doing primary care and HIV treatment, some of the things that we could do. So. If there's no other questions, we'll go ahead and adjourn. And our next session will be the first week in July. And just looking at the calendar, and that would put us as July 6th. Is that right, Missy?
Yes, Dr. Ladd. It's July 6th.
Perfect. Very good. And I think that we have a case submitted